Hello, everyone. It's my pleasure and my honor to welcome you tonight to one of our weekly online series. On behalf of the Educational Board of the Mega Medical Association and the Egyptian Society of Anesthesiology, I would like to welcome the speakers, moderators, and attendees to the creative and prestigious continuous opportunity to deliver not only an up-to-date curriculum in the field of anesthesiology, critical care, medicine, and pain, but also to gather unique speakers and moderators from all over the group. This opportunity is and will remain a great and successful experience in the current and the future virtual learning. Let me introduce Dr. Gloria Rodriguez Vega tonight. She's better known as Glory, and she's a Puerto Rican-born internal medicine critical care neurocritical care specialist, a magna cum laude graduate from the Cornell University, and later cum laude from the Universidad Central del Caribe School of Medicine. She finished her internal medicine residency at the VA Caribbean Healthcare System, and afterwards completed her critical care medicine fellowship at TMH Brown University. She returned to her beloved PR to direct the VACS Surgical ICU for 6 years, after 4 years directing the UDH Neurosurgical ICU. She moved in 2010 to direct the Neurosurgical ICU at Jaime San Pablo Caguas, a private hospital conglomerate in the island. At present, she is also a chief of the Department of Critical Care Medicine. She's assistant professor at the University of Puerto Rico School of Medicine, Ponce School of Medicine, and Universidad Central del Caribe School of Medicine. She is currently involved in the numerous international and international societies. She is a council member of the Society of Critical Care Medicine, and she's a president of Consejo Centroamericano y del Caribe de Terapia Intensiva, a former council member of the Federación Panamericano Ibérica on Medicina Crítica y Terapia Intensiva, and past president of the Puerto Rico Society of Critical Care Medicine. She has been a speaker at the local, national, and international level, and has publications in peer-reviewed journals, authored books, chapters, and is a co-editor of the books Critical Care Administration, labeled A Comprehensive Clinical Guide and COVID-19 Pandemic Lessons from the Front Line. She lives happily with her beautiful daughter, 2 opinionated dogs, and an understanding husband. Dr. Rodriguez, it's all yours now.
Thank you, Ahmed, for that kind introduction. And I am excited to present this panel. We will be talking about sepsis, and as you know, sepsis is a medical emergency, and it is the final common pathway to death from most infectious diseases worldwide. 1 in 5 deaths worldwide is associated to sepsis. Sepsis is the #1 cause of death in hospitals, the #1 cause of hospital rehospitalizations, and there are significant healthcare costs associated to this disease. On September 13th, we celebrate the World Sepsis Day, and this event is part of that celebration. And as you know, this is an internationally recognized initiative of the Global Sepsis Alliance, which aims to increase public awareness and show support and solidarity with the millions of people of the world whose lives have been affected by sepsis. Here at MEGA, we have prepared this program with sepsis as a recent update with opinion leaders in this topic. And it is my honor to introduce our speaker is Dr. Javier Perez-Fernandez. Javier is also a dear friend of mine. We trained together, and he has been not only a mentor, but a sponsor for me. He now serves as Medical Director of Critical Care Services at Baptist Hospital of Miami. He's a Clinical Associate Professor of Medicine at Florida International University, Herbert Wertheim College of Medicine, and also a member of the Florida Acute Surgical Task Force. He's originally from Pamplona, Spain. He completed his medical degree at the University of Navarra and came to Puerto Rico to train at the University District Hospital, internal medicine, and then pulmonary medicine at the VA Medical Center. He completed critical care training at Rush Presbyterian at St. Luke's Medical Center in Chicago, under the mentoring of Phil Dellinger and Parrillo. He manages a large group of critical care physicians, South Florida Critical Care Services, and he oversees the operations of 7 ICU and over 350 ICU beds. He has been a regional and nationally recognized leader during the COVID-19 pandemic. He had multiple TV and media appearances and consultative services for several national and international organizations. He has been directly involved in the development of rapid response teams, technology implementation, and an open ICU model. He has been a speaker from national, worldwide, and is frequently invited to share his knowledge in international forums. He is treasurer of the Federación Panamericana Ibérica de Sociedades de Medicina Crítica y Cuidados Intensivos, and also Latin American Leaders Committee of the Society of Critical Care Medicine, and the Secretary General of the World Federation of Intensive Care Medicine. He is author of many publications and peer-reviewed articles, and also co-editor of the book Critical Care Administration, a Clinical Guide, and the 7th edition of the Society of Critical Care Medicine's FCCS. He will be talking to us about an update on the treatment and management of sepsis. Welcome, Javier.
Thank you so much.
Originally from Pamplona, Spain, he completed his medical degree at the University of Navarra and came to Puerto Rico to train at the University District Hospital, internal medicine, and then pulmonary medicine at the VA Medical Center. He completed critical care training at Rush Presbyterian at St. Luke's Medical Center in Chicago
I'm going to share my
under the
screen
mentoring of Phil Dellinger and Parrillo.
into this particular talk.
He manages a large group of critical care physicians, South Florida.
I'm going to try to summarize some of the most recent guidelines on regards to the recognition and management of sepsis. And having said that, I think Dr. Hidalgo's presentation has opened us the eyes on how things are moving in the future to recognize and to understand the pathophysiology of sepsis. I think the guidelines and the definitions that we've been dealing with for over 20 years are becoming a little bit, I will say, not accurate for the definition. And Glory, you actually had particularly placed several questions in that particular item, which I think are eye-openers for most of us. The fact that we can really recognize sepsis timely, the fact that sometimes not all patients fit into the same classification. So with that said, let's move into what we have defined today and what really guides our clinical management of patients with sepsis. And of course, first of all, in my disclosures, I have the same interest that Dr. Hidalgo has mentioned. Technosepsis is probably the most important sepsis meeting this year in 2022. And it will be actually held in Mallorca, Spain, but it will be telecasted and it will be online accessible from everywhere in the world, and it's available to all of you if you go to the website, and there's multiple opportunities to be participant. This is a major event. It will carry out a significant number of worldwide recognized speakers, including most of the ones really making the most recent guidelines and involved now on creating the new guidelines that will hopefully change a little bit of the paradigm of sepsis. And I also would like to announce a book that we have prepared with Marcio and Jorge and Gloria's collaborated, and multiple other fantastic authors. And it will be also available to your purchase and your leisure very soon. So sepsis is definitely an important issue for all of us in the hospitals. It really portrays more than 10% of hospital admissions and about 40% of hospital deaths. And that's worldwide. So the costs are outstanding, and the cost cannot really be reflected on the slide because it all depends on multiple factors. Now, sepsis sometimes has been forgotten, and the mortality continues being very high. And patients that suffer mortality because of COVID, multiple of them actually die out of sepsis. So a virus can cause sepsis, and the pathophysiology of mortality in several cases of COVID had also been linked to sepsis, although for whatever reasons hasn't been mentioned that way. So it is really prevalent, and it affects very, very much all of our institutions. However, for whatever reasons, many times it's not seen with the same lethality or the same, I'll say, label as far as other diseases such as acute myocardial infarction of pneumonia or heart failure. And sometimes when we talk to our patients about sepsis, they don't understand what the concept is. And they understand, however, we tell them you had an infection or you have pneumonia. And that's kind of a little bit of a problem to me, as certainly is not what we really want for our patients to see or to understand about the disease. So when someone suffers a septic problem, the mortality is very high. And if patients don't understand that, or families don't understand that, and governments and institutions don't quite understand that sometimes, well, that is definitely a major issue. So we need to correct that one way or another. So I think understanding sepsis is a timely effort. So something that requires a very timely response, a very specific and accurate management rapidly. Well, it's something important. And the same way that we have done with the stroke, or we have done with acute myocardial infarction, we also need to understand how sepsis, it requires that prompt response and requires the alertness from our team. And that's also tremendously essential for us. One of the problems that we had for many years has been this Babel Tower of many people defining sepsis in different ways. And so we have people understanding sepsis as a pure infection, other people understanding sepsis with an infection and some form of damage, maybe surgeons focusing on surge control, which is tremendously necessary, but then forgotten many times pathophysiologic mechanisms of action and the reflection of those mechanisms in other organs, et cetera, et cetera, et cetera. So you're all familiar with this myriad of different definitions that have complicated many of the studies that we've done, in which unfortunately the reflection of results have been obscured by the presence of different definitions. So, and then we came to the most recent one. About 20 years ago, we started defining SIRS, severe sepsis and septic shock. I was part of those starting definitions back in 1999, 1998. And in 2000, actually, we would publish a book in which we defined sepsis, or attempted to define sepsis. 20 years later, on the Sepsis Codex book that we have now, I actually had to write the same chapter, and I discovered that not much would advance on the definitions of sepsis after 20 years. And again, this is particularly, I would say, fitting to us in some of the aspects, nonetheless. So the definitions are there: the SIRS, the severe sepsis, and the septic shock, and those were really classic. But then SIRS was immediately pointed out as a very, very, very poor sensitive element to define sepsis. And we have this particular young lady running after the bus, and the lady running after the bus in a hot environment, such as could be where I am speaking to you right now, Miami. Obviously, that lady is going to have elevated heart rate, an elevated respiratory rate, and likely an elevated temperature. So those three factors that define SIRS will be present on this young lady, who is certainly not having SIRS, might be having urgency to catch the bus, but certainly not SIRS. And if the lady happens to have a urinary tract infection, here we go. The patient now is septic with severe sepsis. And the answer is definitely not. And we understand that. So there's a poor sensitivity and some of the concepts that we use to define sepsis. And we need some clinical understanding of the process in order to define sepsis. And certainly this is one of the major problems. So in 2001, we also started managing sepsis differently, and we created some guidelines on how to manage sepsis. So not only the definitions, but also the treatment. And those treatment guidelines were essentially based on a famous paper that was published by New England Journal of Medicine, in which Emmanuel Rivers presented the early goal-directed therapy. And those were obviously amazing results and a standardized management of patients with sepsis. Now, very shortly after, it was definitely a different definition, but let's put it that way. So at that point, I think what really was very important was the establishment of, again, a timely response to manage sepsis. So the early goal-directed therapy, the AGDT therapy, or the AGDT criteria established a 6-hour protocol in which the 3 first hours were probably the most important ones. And that created an amazing response from institutions and practitioners that they try to manage those patients with sepsis or suspected sepsis in those first 3 hours, in provoking certainly a mortality reduction. Now, when 3 large trials, one in Australia, one in the United Kingdom, and one in the United States were done, in which they compare the standard management of sepsis compared to using early goal-directed therapy, there was really no difference on mortality. So what really matters was the awareness of the disease and the awareness of the need to manage those patients rapidly. So again, patients with sepsis require very early management, rapid decision-making, and an establishment of treatment, moreover, if it's appropriate, in a very rapid fashion. Now, more definitions, more standardization came in after the Surviving Sepsis campaign was established. And again, as a response to the multiple differences on definitions and management, back in 2012, the Surviving Sepsis campaign published their first international guidelines. At that time, it was interesting to show some hospitals, and this is a particular slide that Mitch Levy published in Critical Care Medicine in 2015. When hospitals, institutions adhere to the Surviving Sepsis campaign motive, so when they decided to participate in the Surviving Sepsis campaign and establish protocols, simply by the awareness, simply by creating those protocols in the hospital, there was a significant reduction on the mortality that was observed. So that's called the participation effect. That's seen in other trials for other diseases too. But this is, again, another proof or another another help to understand that just simply the awareness and the rapid management made an interesting point. And then we come by with 2 other definitions in the middle to the most recent definition update. That was 2021. And in 2021, the definitions, the latest definitions came in on board, the latest guidelines came in on board and were published. And this, from the following 10 minutes, will be a little bit of a summary of what those guidelines brought to us. And when they brought to us, if there's anything different to what we already know. And again, this is at no point an attempt to review all simple guidelines. There's 93 particular recommendations. And so we can't review the 93 of them, but I was trying to make a little bit of some points on the most important changes that happened between the previous definitions that have been going on for the last 10 years, as opposed to the most recent ones now coming in the last year and a half. So first of all, I think the definitions have now changed from 2016. And again, critiques and favorable points. The favorable points is the 2016 definitions already brought into account that the host response was important on the appearance or on the pathophysiology of sepsis. So not everybody who gets a urinary tract infection happens to have sepsis. Some people react to the infection by their own host response, creating a dysregulated answer or a dysregulated response that was really what we call sepsis. So that is part of the definition now. There's also a definition of septic shock that includes the presence of hypoperfusion. So hypoperfusion is obviously the major representation or the flag for understanding septic shock. And hypoperfusion is most times reflected in an elevated lactate level. So those two elements are maintained on the definitions. And then the next question of the critique is, why are not looking into phenotyping this? Why are not looking into particularly adding some other biomarkers or not? Well, probably because we don't have any that can be pointed out as the clear definitory for sepsis, or maybe because our knowledge is not good enough yet, and we need more information and more studies. And maybe later, Marcio Borges will give us some more hints about that, as Dr. Hidalgo has given us some ideas from behind. So that's a part of the definitions. Now, there's a couple of things with the campaign. Obviously, there's 93 recommendations, as I told you. And there are recommendations about new aspects in sepsis that were not recovered in the 2016 previous guidelines. While they talk about capillary refill time, they talk about empiric MRSA, methicillin-resistant staph aureus coverage, also about empiric fungal coverage. They touch high-flow nasal cannula and non-invasive ventilation, but I actually came in very adequate as far as the COVID-19. That was actually happening while this publication occurred. And the use of ECMO, that's also another point that was being used as well during the pandemic. And an important point, which is the post-ICU follow-up for patients with sepsis. So there are key modifications, and those key modifications, again, included the recommendation for a bolus of 30 milliliters per kilo. And that was a strong recommendation in 2011. It was a very strong recommendation in 2016. And now it's being downgraded as a weak recommendation because our quality of evidence is not as good as we thought it was. And also, they finally made some point about the use of balanced crystalloid solution as opposed to normal saline for resuscitation, and they recommended balanced crystalloid solution, such as Ringer solution. Now, also another important point in this guidelines update is the use of vasopressors. Now, again, time of senescence, time being in essence, again, the use of vasopressors cannot be delayed to place a central line. If a peripheral access is available, this is a good opportunity if the patient needs it to start, again, vasopressors without further dilation. In addition, they talk a little bit about vitamin C. That's been the subject of a couple of studies in the last 5 years. And again, the follow-up that I will mention in a little bit. So let's talk a little bit about the sepsis identification and what the guidelines says about it. So the guidelines touch the topic of sepsis identification, how to screen for patients with sepsis, and how to screen for patients with septic shock. Now, in the major recommendation they can have is to establish protocols, programs to include sepsis screening for patients with high risk to develop sepsis. And again, it's vague if you think about it. There's no particular element. It's not a point of saying, if you have this, you have sepsis. But it's, again, an opening statement. You have to be aware, number one. Second, you have to establish mechanisms for early recognition and management. And if you don't have that in an institution, if you leave that to everybody's effect, probably the results will not be what you're expected to be. As far as the recognition, is there any particular element, code, any guidelines, any criteria to use? And I think for the last 5-6 years, so far, the sequential organ failure assessment has been widely used for some people who are not necessarily intensivists to define screening for patients with sepsis. Now, this is really the recommendation. So far, or Q-SOFA, which is the modified quick SOFA score, should not be used to recognize patients with sepsis. Q-SOFA was intended to determine the mortality, the severity of patients with sepsis, and is not to determine the presence of sepsis. So other criteria, other methods, such as SIRS, NEWS, or MUSE, could be used. Now, the recommendations were based on previous, again, guidelines, but definitely in this case, the committee, the Surviving Sepsis Campaign, has recommended not to use Q-SOFA to define the presence of sepsis. And again, this is very important because in multiple occasions, we've been encountering this in institutions where we are, quality instruments are being using Q-SOFA to determine the presence of sepsis. And this is definitely not adequate because it's not to define the sepsis or to screen for presence of sepsis, but just to define the severity of patients and their outcomes of future outcomes. Next, we'll talk about the first hour. For the first hour, for the last 10 years, we recommended to use lactate, to measure the lactate. Culture patients before antibiotics were given. Administer broad-spectrum antibiotics. Given fluid resuscitation of 30 milliliters per kilogram if hypotension or the lactate level was elevated. And finally, using vasopressors if the mean arterial pressure was in this case, if the mean arterial pressure was lower than 65 and not more than 65, as it says there. So again, is the fluid 30 milliliters per kilo the adequate amount? And it was a strong recommendation, the last two guidelines, but it's not as strong right now. And now it is recommended, but not a strong recommendation. And it's actually a suggestion. And it should be given within the first 3 hours, but you also have to look into the patient response. And the additional vasopressors can happen before that fluid resuscitation is ended. So there is weak, low quality of evidence defining 30 milliliters per kilogram. And moreover, some people have argued, why not 25 and why not 35? And there is a couple of new results in a couple of new trials suggesting that maybe too much fluid could lead into worse outcomes for some patients. So this strong recommendation was downgraded to a suggestion, but certainly it needs to be initiated promptly. So you're going to give fluid, give it soon and not wait too long. Again, those are quick examples on the last 5 years, different trials in which the use of 30 milliliters per kilogram of fluid challenge has been challenged, if you allow me to say it that way. Now, again, there's insufficient data as well to consider the restrictive management of fluid versus liberal fluid management is different or shows any different outcomes. So there's definitely no recommendation at this point suggesting that restriction of fluid is better than not restriction of fluid. So also, crystalloids are the first recommendation. And it's a strong evidence suggesting that. Also, there is a strong, there's a recommendation or suggestion of using balanced crystalloids versus non-balanced crystalloid. Again, ringer lactate versus normal saline. Although there's still not good evidence to suggest or to support this. Now, the use of albumin is also weak as far as the evidence. So, but I think we have better evidence. If you use already 2 or 3 liters of saline and there's no response, in those cases, there's a little more evidence to suggest that maybe using of colloids such as albumin could be adequate, but definitely not starches. So the recommendation about the use of starches, so head starch or any one of those, is definitely against it, against the recommendation. And there's very good evidence supporting that the use of head starch, as an example, It's not beneficial, and it could actually be detrimental. So same thing for gelatins. Now, there's worse evidence about this, but it's definitely enough evidence also to suggest it's not adequate to do. So now the antibiotic part. So are we ready to start antibiotics right away, or we need something such as procalcitonin? In many institutions, people are drawn at procalcitonin level. And if procalcitonin is low, they do not start antibiotics. And they're waiting until that to happen. And the answer is do not use procalcitonin, and especially do not wait for the results of a procalcitonin test in order to start antibiotics for a suspected patient with sepsis or a patient with suspected sepsis. Now, and that goes again with the antibiotics. So delaying administration is associated with an increased mortality, and we know that with a strong evidence. The sooner antibiotics are started, the better outcomes occur with an infection. And do not delay to obtain blood cultures either. Broad spectrum antibiotics must be adjusted and even discontinued after organisms are identified. So if you decided to start 3 antibiotics, de-escalate into only 1 when you have identified that this organism, let's say, is a gram-positive versus a gram-negative, it's fungal versus a bacteria, it's totally adequate. The procalcitonin might be used to adjust the length of the treatment, although there's very, very, very low level of evidence about it. And so it might be useful to determine when to discontinue therapy. But again, the level of evidence is low about that. So the panel only have a very weak recommendation about this. Lactate is definitely our best surrogate to determine tissue perfusion. So there's a couple of studies well done that shows, when I say a couple, I don't mean literally a couple, I'll say a few studies showing that the measuring lactate and following the levels of lactate to target therapy might be a good way to reduce mortality in patients with sepsis. Now, the use of high flow nasal cannula and is being recovered and touched during these recommendations. So high flow nasal cannula is better tolerated sometimes than non-invasive ventilation. High flow nasal cannula has had a tremendous jump during the COVID-19 pandemic, and certainly is very useful. This is well tolerated for most patients as opposed to non-invasive ventilation. Now, the panel recommended the use of high flow nasal cannula over non-invasive ventilation in case of hypoxemic respiratory failure. The recommendation is weak, and the low quality of evidence is weak. And some critics have come to say, well, this came in the adventure of the COVID-19, and it might have been a little bit biased because there's really no evidence to suggest that it's better than non-invasive ventilation. Certainly a great instrument to improve oxygenation and sometimes to reduce on a mildly level the work of breathing, and also the dead space ventilation in some aspects. But whether it is compatible with non-invasive ventilation to the level to recommend in septic patients, that might be something that would require further evidence to come. Now, let's talk a little bit about the blood pressure and why the guidelines have recommended now early use of vasopressors. Well, it is clearly a demonstration that low mean arterial pressure provokes tissue damage. So the probability to happen to have tissue damage, in this case, on the left of the slide, acute kidney injury, or in the right, myocardial damage, because your blood pressure goes down, increases significantly with the level of the decrease, or with the level of drop with the mid-arterial pressure. So if your MAP goes below 60, as you can see in the left side of the screen, now your chances of having kidney injury are about 6%. But if it goes below 40, your chances duplicate So a drop in 50% of the blood mean arterial pressure increases your chances of developing kidney injury by 100%. The probability of myocardial injury goes in a similar fashion. So in a mean arterial pressure of 60, your chances are about 2%. Whereas in a mean arterial pressure of 40, it goes to 6%, so 3 times, threefold increase in the probability of having a myocardial injury. Well, that's low mean arterial pressure. So that explains why there's the need for vasopressors, but doesn't explain the need for promptly initiation of vasopressors yet. But here is the thing. The duration of a low mean arterial pressure is also related to the amount of tissue damage. So the longer your low mean arterial pressure remains, the more the chances that you have damage in your tissues. If you can see that, the chances for you to develop kidney injury at whatever level of MAP is almost go double or increase by 50% from 5 minutes of duration of low MAP to 20 minutes. So if your patient remains with a low mean arterial pressure over 20 minutes, your chances of developing acute kidney injury go up by 1.5 folds. Same thing with cardiac complications, whether it's arrhythmias, whether it's others, or myocardial damage itself. So that's why the prompt intervention with vasopressors becomes more and more important, and not to wait until there's 3 hours of fluid resuscitation to initiate. And that's what, again, the use of vasopressors now is suggested to be started as soon as there's refractory increase of the mean arterial pressure, despite the fluid resuscitation happening. The first recommended drug is norepinephrine with a strong recommendation. And again, there is high evidence of quality, and there is also very, very good quality of evidence for the use of the dopamine, very good but moderate quality for vasopressin, and epinephrine and cilopressin have lower quality and very low quality for angiotensin II, which is the newest one. Now, again, if you have someone on a level of norepinephrine that has not responded adequately to that, there is a recommendation to start escalating the dose of also the add vasopressin instead of escalating the dose of norepinephrine. This is very weak as far as recommendation. There's moderate evidence suggesting that. And again, this is important to consider as well. Now, interestingly, the corticosteroids have been on the horizon for a long time. It's probably as long as humanity has been there. In this case, we have a very, very uncomfortable decision because they're really, in this case, there is a very weak recommendation that if the patients do not respond to the normal treatment, there is recommended to use IV steroids, and the dose is 200 milligrams per day of hydrocortisone or equivalent. And this is obviously at least 4 hours after the initiation of vasopressors. So if someone has not responded within 4 hours to the use of vasopressors, there's a high recommendation for the use of steroids. Now, I think one of the things for glycemic control is now that we are already far away from the very strict or tight blood sugar control. We're definitely not recommending that. Keeping blood sugars between 180 and 110 is the adequate management. So 110 being the lowest, 180 being the highest. And I think one of the biggest things is to establish a protocol in your intensive care unit that includes the use of insulin rapidly when the patients do not have an adequate control of blood sugar. Now, vitamin C has been subject of a couple of studies, and there is evidence to recommend not to use it. And vitamin C has not been producing any evidence whatsoever of improvement in mortality in septic shock or sepsis at all. So some studies, very, very small studies, were trying to be also used in COVID-19, and they resulted in no evidence whatsoever. Now, in some countries, the use of blood purification systems, so hemoperfusion, have been suggested and are being promoted. And the committee and the guidelines recommend against the use it because there's insufficient evidence to make recommendations as of now. Now, this doesn't mean that if you have it available, as we said in COVID-19, well, you might be beneficial for some particular patients or not, but certainly not in general. As it's not in general recommended the use of immunoglobulins either, because of the low quality of evidence. Now, transfusion continues being used if the hemoglobin below 7 occurs, unless the presence of a cardiac event is there, in which case then this can be elevated to levels between 8 and 9. But increasing oxygen delivery capability of the blood by delivering more blood, if the hemoglobin is 8, is not adequate, neither shown any benefit for the patient. Same way with the platelet transfusion. So unless there's evidence of bleeding or high risk of bleeding, in which case the 20,000 is the marker, then there is absolutely no indication for platelet transfusion. Again, unless it goes below 10,000, or unless the need for procedures are to be done. I think one of the major things that the guidelines have come with is recommended assessment and follow-up of patients that are being discharged from the intensive care unit and even from the hospital with sepsis, because of the evidence that those patients suffer post-critical illness problems, such as neurologic, cognitive, or physical problems that might be contributing to additional problems for those patients. So maybe a way to improve mortality and morbidity for those patients is to follow them, having a very robust program of follow-up and maybe rehabilitation or support for those patients as an outpatient. I want to say goodbye to you, and really like to thank you, everybody, again, reminding the opportunity to attend to the technosepsis in October 5, 7, and to, of course, get the additional information on the book. And remembering everybody that we need to be clinicians, and the protocols must serve as a guide, but they're not the laws that govern our practice. We have to individualize the treatment and look for very, very exciting news that will come in the future about management of sepsis. Thank you so much for the attention.
Thank you, Javier, for that very stimulating update on our critical care guidelines, treatment and management. I want to continue the conversation, adding that, as you know, maternal sepsis is the #1 cause of death for obstetric women in underdeveloped countries. The #1 in the United States, it's hemorrhagic shock. And also 40% of the cases in children under 5 of sepsis. And as you mentioned with the Surviving Sepsis Campaign guidelines, mortality has decreased after Surviving Sepsis Campaign guidelines. And one of the reasons I think for that is that also with the bundle. So you have your evidence and you've translated that to implementation tools. Knowing there are certain controversies with the Surviving Sepsis Campaign guidelines, but I want to ask you, as an administrator and as a consultant that you are, what recommendations can you give us to make it easier for clinicians, and not only intensivists, any clinician encountering sepsis, to further reduce this mortality in sepsis?
Well, I think you make two important points, and number one is what I said is the forgotten phases of sepsis, and obviously when we talk about sepsis, we all intensivists think of wow, yes, this patient on the ICU with a pneumonia or with some form of surgical infection, but we forget the cases that sometimes not even come to the ICU, such as the maternity cases, post-obstetric cases, right? Or as I mentioned before, the COVID-19 patients that were also affected with sepsis, right? And I think it is important to establish and to make
फोन
in
करें ना
our
विधि को बात करें
institutions.
जैसे हम लोगों को फोन करके बोलता है विमल मेरी बात करो
Could you please silence your, thank you.
So,
Go ahead, Javi.
Yeah, no problem. Yeah. So I think one of the issues is again to establish clear and robust protocols in every institution that help to guide the clinicians and their management. And I think for most of us, and I'll give you an example of a couple of the institutions that I've managed or have been involved with the management, in which we have to have amazing campaigns of education to external services from the ICU, and particularly the sepsis, the code sepsis is one of the examples of that, in which again there is clearly education and trying to spread the knowledge of sepsis. So people, when they see patients with sepsis, they get immediately thinking of the disease and not thinking about, oh, this might be a complication of. Well, it doesn't matter where this is coming from, but it's sepsis. And then it needs to be managed accordingly. So with the time and management, with everything that you just mentioned. And I think, again, education becomes essential in this.
Thank you. One question before we go with Dr. Borges and Marcia's lecture. The other thing is 80% of the septic patients occur outside the hospital. So what is the role, and I know we've spoken about this before, of ICUs without walls, and what does that mean, and how would that impact in decreasing sepsis mortality?
Well, excellent question, and that was part of our Code Sepsis and the Sepsis Foundation meeting last March. I think one of the major problems with sepsis is that when we think of sepsis, we think in our ICUs, and again, unfortunately, the majority of sepsis in the world happens outside the hospitals you mentioned. And when we look in some particular areas, this is even more notorious. So we can't really have an ICU in the mountains of some countries in Latin America. We certainly can have it in the rural areas of the Midwest of the United States. However, we definitely have the opportunity to provide, especially now that we learn how to do that with the pandemic, using modern technologies to help identification and management of those patients. So telemedicine, virtual use of availability of protocols, centralization of services, all those are words that obviously every region, every country, every area will have to develop differently, right? And I'm not here to give a lecture about it, though it might be a very good topic for the next one, right? But I think this is very, very, very eye-opener for most people, that when you look into what we talk here about sepsis and our procalcitonin and all those things, in many areas of the world, it doesn't really matter because people don't go to the hospital, they can't arrive. So discussing vasopressin versus norepinephrine is great for us, but it's not good for 80% of the patients that die out of sepsis. And you're absolutely right. So this is something that in the next decade, just to say something, right? We definitely need to tackle, and we need to create instruments in which we are very fortunate to account with this. We can spread that and fight sepsis where really it's hurting people. And I know Marcia might be saying a few things about it, so I'm not gonna step more into that, okay?
One other thing, since we're pushing boundaries of knowledge and going through the theme, I think one of the things of reducing that sepsis mortality is first by preventing sepsis. So, and how should be this approach in a multidisciplinary way? And this is not only a medical healthcare issue, this is a public healthcare issue. Can you expand a little bit more and set the stage for Marcia?
Yeah, so I think absolutely, again, a great point. So everything that I discussed is everything to do with the management of the patients not only in the hospital, but also after the ED, after the hospitalization, pretty much. Before that, a huge, humongous stage happens for people. And as you say, if we don't talk in our sepsis congresses, in our sepsis conferences about preventing obstetric sepsis, how to maintain adequate hygiene, sterilization of instruments, adequate closure of the OR areas. If we can talk about water, simple as water. So water is a problem to transmit diseases in 60% or more of the cases of sepsis. And if we can talk about how to manage that based on public health policies,
And
based
vaccination.
on, right, vaccinations, exactly. So all those are the major impact point for the majority of people. So what we're trying here is to solve a problem and the peak of the problem, but we're not realizing that the major issue becomes now the basics on it. So you might be excellent. I might give you just an analogy to leave this open for Marcio. You might be excellent managing, you know, the best of the lung cancer tumors, but if you don't make people stop smoking, most people will continue dying, because even if you cure 50% of 10 million is way more than 50% of 100. And that's the problem.
Thank you, Javier.